Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Vera Therapeutics.
Hello, everyone. Welcome to this presentation, New Frontiers in IgA Nephropathy, Understanding the Role of B-Cell Modulation. This has been supported by an educational grant from Vera Therapeutics, and the program has been developed through a strategic partnership between KDIGO and Medscape Education. I'm Professor Jonathan Barrett from the University of Leicester in the UK, and I'm joined by my good friend Kirk Campbell. Kirk, would you like to introduce yourself?
Absolutely. Thanks, Jonathan. So I'm Kirk Campbell from the University of Pennsylvania.
So let's get started. So I'm going to concentrate on thinking about the B-cell pathway and its importance in the generation of pathogenic IgA and the driving formation of immune complexes and kidney damage in IgA nephropathy. So when we think about the overriding pathogenesis of this very common form of kidney disease, we believe that the major abnormality is a dysregulation within the immune system that drives the production of pathogenic IgA that enters the circulation, and within the circulation forms these immune complexes that ultimately deposit within the glomerular mesangium, where they can trigger inflammation, scarring, and ultimately loss of kidney function. We believe that fundamental abnormality, based predominantly on genome-wide association studies, is occurring within the mucosal immune system, where there's dysregulation of control of IgA production with the release into the circulation of pathogenic IgA, which appears very much like the mucosal IgA we see in our secretions. In the circulation, these form immune complexes by combining together as self-aggregates, combining with other serum proteins, and combining with anti-IgA glycan antibodies. We can measure these in the laboratory. We can't measure them in clinical tests at the moment, but they're clearly there and they clearly drive that injury that we see causing loss of kidney function in IgA nephropathy. So what is the fundamental abnormality within this mucosal dysregulation? Well, to understand that, we need to understand what controls IgA production, both in health but also in disease. And IgA is produced from plasma cells, which are derived from naive B cells that undergo IgA class switch recombination. And that IgA class switch recombination can be under both T cell dependent and T cell independent control. The IgA producing plasma cells, particularly within the mucosal immune system, generate polymeric IgA that lacks terminal galactose on the IgA1 hinge regions. And we often call this type of IgA Gd-IgA1. And these IgA molecules are sticky, they stick to themselves to form aggregates. And as I'm sure you're aware, there are anti-glycan IgA and IgG antibodies in the circulation that can recognize these Gd-IgA1 molecules and promote immune complex formation. Now, we don't know whether these anti-glycan antibodies are formed through true autoimmunity or whether they're actually antibodies we develop against commonly encountered microbial pathogens. And it's just bad luck that these antimicrobial IgA and IgG antibodies recognize this Gd-IgA1. When we think about the maturation of B cells, we have those pluripotent stem cells that go through a process of differentiation to ultimately form immature and then mature but naive B cells, which on encounter with antigen undergo affinity maturation and class switch recombination, ultimately to produce mature antibody that helps us fight infection. And it is the plasma cell that drives the production of antibodies. And you can see here, there are two key cytokines that control this entire process. And these are BAFF and APRIL. BAFF is predominantly controlling those early stages of B cell development, and APRIL, the later stages of B cell maturation and survival. And both of these cytokines are critical to the coordinated control of B cell development and the production of mature antibody that helps us fight infection. But what we have understood over the last few years is that dysregulation of BAFF and APRIL synthesis and signaling can drive a range of different antibody mediated kidney diseases. And perhaps most importantly, these dysregulation of these two cytokines seems central to the development of IgA nephropathy and the production of that pathogenic IgA that ultimately forms the immune complexes that deposit within the glomeruli. So the great news for us and for patients is we now have the ability to target this dysregulation of BAFF and APRIL with a variety of new drugs. Some are in phase 3 and some are in phase 2. We have 2 drugs that specifically target APRIL alone, and these are sibeprenlimab and zigakibart. And then we have 3 drugs that allow us to target simultaneously both BAFF and APRIL, and these are atacicept, telitacicept, and povetacicept. Now, what we're going to do over the next few minutes is go through the data supporting these drugs as a new treatment for IgA nephropathy. We're going to focus on atacicept and sibeprenlimab that have phase 3 data. Telitacicept has only been developed in China, so we're not going to talk about that in great detail. And then we will mention those data that exist for the drugs in early phase 2 development. So I'm going to hand over to Kirk now, who's going to take you through the data for sibeprenlimab and atacicept.
Yeah, thanks so much, Jonathan. So as you've heard, we do have some interim phase 3 trial data, which we're going to summarize. So the visionary phase 3 trial, as we know, recently published, sibeprenlimab versus placebo. Again, the enrollment was 259 patients in the treatment group, 251 in the placebo group, with, again, plans for an open label extension. And of course, we do have the benefit, as I mentioned, of the interim analysis in a subset of these patients. So we know from the baseline characteristics of those individuals that have been reported out that we do see a good representation of the burden of IgA nephropathy. We do have, again, a predominant male enrollment. We do again have a significant number of individuals of Asian ancestry. Again, understand the predominance, right, of IgA nephropathy within certain ethnic groups. And of course, this was a globally enrolling study with a nice geographic balance. We did have, again, about 15% of patients in the treatment group in North America, and again, about 13% in the placebo group. And you can also see all the baseline characteristics around hypertension. We do, of course, want to have good blood pressure control before patients are randomized in these studies. You do have, again, relatively preserved EGFR, again, mean of 63.5 mLs per minute in the treatment group and a similar number in the placebo group. The patients, by and large, had hematuria documented by dipstick, and we can talk a little bit more about that. And as we're increasingly seeing in these studies, a significant number on SGLT2 inhibitors, and encouragingly, patients, again, are getting ACE or ARB treatment, which, again, we know is foundational. And of course, the results that many of us are familiar with, we did see a little over 50% reduction in percent proteinuria decline in the treatment group, with a slight increase, about 2% in the placebo treated group. Which again kind of highlights some of the efficacy that's been encouraging in a number of IgA nephropathy studies. But as Jonathan will point out, there may be some differences in the GFR data that we're seeing from some of the earlier phase 2 studies. Encouragingly, the reduction in proteinuria was seen relatively early, right? So even though we're kind of discussing 9-month proteinuria reduction data, we are seeing as early as 8 weeks, you're seeing a significant decrease, right, in proteinuria, which again is good for patients and encouraging for this drug class. And the subgroup analyses did show a benefit across different ethnicities, genders, age groups, race, and then geographic distribution baseline information, which again is overall encouraging. And of course, as we mentioned, this is a subset of patients, right, that we're reporting out on with full data to follow. And similarly, patients that had less than 2 grams or more than 2 grams benefited to a similar degree. And those with GFR over 45 versus the 30 to 44 range also benefited, as did those individuals who were or were not on SGLT2 inhibitors. So again, reassuring for patients regardless of a treatment group. And of course, we would love to have more biomarkers available to guide our decision making and to track clinical outcomes for these patients. And again, Gd-IgA1, which Jonathan covered, we did see a reduction in the patients treated with sibeprenlimab and did not see that reduction in the patients who were treated with placebo. Likewise, APRIL levels, and again, this is, as Jonathan mentioned, an agent that is targeting APRIL. We did see a reduction in APRIL levels that were significant from baseline, right, in the treatment group, but not in the placebo group. The drug was, again, relatively well tolerated. We did not see a significant increase in adverse events in the treatment group compared to placebo. And again, this table nicely summarizes that. Of course, you're targeting APRIL cytokine with a theoretical, again, potential risk for infection in these patients, which we did not see an increase of, which again has been something we've been seeing across the APRIL-BAFF clinical trials that have been reported out. And again, likewise, we do have reports of some injection site erythema and pain, but again, not different between sibeprenlimab and placebo treated groups here. And of course, the safety data were reported out for the entire cohort, so not that subset where we had efficacy data reported. So Jonathan, I don't know if you had any thoughts on the sibeprenlimab data or any points you wanted to highlight before we talk about atacicept.
Yes, I mean, I think it really reinforces the critical role for APRIL in the development of IgA nephropathy in terms of what we're seeing when we block APRIL. We can see that reduction in proteinuria, the reduction in hematuria, we can see reduction in that pathogenic form of IgA, all things we would hope to see with a drug that is truly attempting to modify the fundamental aspects of the disease. And of course, the thing we really are looking forward to is the GFR data, which we don't have access to yet, but hopefully in the near future. But I think really reinforcing the importance of what we found with those early preclinical studies and the genetic data that actually identified genetic variation in the gene for APRIL, but also the gene for TACI, the receptor for BAFF and APRIL, as a genetic risk factor for IgA nephropathy. So again, really nice story here. Very basic science data supporting a target, a clinical trial targeting APRIL, showing clinical benefit. It's a really lovely story.
Absolutely. Couldn't agree more. So on that note, since you mentioned BAFF, atacicept, of course, is targeting APRIL and BAFF in this case. And we also had a report out recently from the Origin phase 3 study. Of course, we had 428 patients who received either the study drug versus placebo. And then we have the interim analysis report out of 106 patients in the treatment group versus 97 in the placebo. And we can talk about some of that data. So again, these are the baseline characteristics. We do, again, see mostly male patients, and again, a lot of patients of Asian ancestry, but again, well balanced in terms of the ethnic distribution of individuals who were enrolled. We did again see, a majority of patients with hematuria. In this case, we do have a more detailed breakdown of the degree of hematuria, right? Negative or trace in one group versus 1, 2, 3 plus. You can see documented there. Again, significant proteinuria, 1.7 versus 1.8 grams. And again, GFR relatively well preserved. You see also the baseline immunoglobulin levels documented, as are the galactose deficient IgA levels here as well. And again, as we just mentioned, increasingly we are seeing patients on SGLT2 inhibitors as well as maximized RAS inhibition prior to enrollment in studies. And the biopsy vintage, again, even though a lot of these studies will allow patients to have kidney biopsies that may not be that recent, you are seeing about a 2.5 year biopsy vintage prior to enrollment. So in terms of the results, again, encouragingly, we are seeing about a 46% reduction, right, in UPCR at 36 weeks for atacicept versus about a 7% decline for the placebo group, which again is, of course, a significant difference. And again, you are seeing as well that reduction in proteinuria that is happening again by the 12-week point or a little bit earlier. So again, encouraging early response that's also sustained throughout that interim analysis period. And Gd-IgA1 levels again are reduced here, 68% in the atacicept group, reduced by 2.9% in the placebo group. And of those individuals that had hematuria documented at baseline, you did see 81% of them had a decrease, right? A resolution of hematuria with atacicept treatment, with about 21% of those individuals at baseline hematuria seeing that same resolution with the placebo treatment. So again, that is a significant difference for those individuals. And I'm sure we can have a lot of conversations about the utility of following hematuria in these patients and whether or not that's useful as a potential surrogate for ongoing glomerular inflammation. We could certainly have that discussion. So the subgroup analyses, again, you see the distribution where individuals, regardless of age, sex, geographic region, race, baseline proteinuria, baseline EGFR, or whether or not they're using SGLT2 inhibitors, they did appear in all those groups to have a significant response to atacicept treatment. And again, this was also a well-tolerated intervention with mainly mild or moderate adverse events that were documented, not significantly different between the treatment and placebo groups. Again, the injection site reactions we have seen. In this case, you are seeing more of them with atacicept group, but again, we're in the more mild, moderate category. Not a significant increase in infections that were documented, which again is overall encouraging. And again, infections are an area that we want to pay closer attention to and really want to highlight the serious adverse event related to infection infestations. Again, not occurring right in the atacicept group. In fact, just a little bit few of them documented in the placebo group. So Jonathan, any thoughts on the atacicept data?
Yeah, again, a really lovely story, isn't it? Understanding the biology. We know dysregulation of APRIL, but also dysregulation of BAFF can drive IgA nephropathy, both from animal models and from human data. And seeing these data and showing such a clear clinical effect with reductions in hematuria, proteinuria, and reductions in that pathogenic form of IgA, really exciting data. And what's even more interesting is the fact that we're not getting a safety signal here. Even when we're blocking both BAFF and APRIL in these patients, you can see the data here. It's a very safe profile, accepting it's a 9-month exposure, but we're seeing that actually this is a drug that could really be beneficial to patients without potential safety concerns based on the data we have at the moment.
Thanks so much. I'll hand it over to you just to go over some of the phase 2 data.
Yeah, so I'm going to be very brief here because you've already spoken about atacicept and sibeprenlimab. We have early phase data for zigakibart and povetacicept. Again, very similar to what we've seen from the phase 2 data for the other agents, with a highly clinically relevant reduction in proteinuria, a relatively clean side effect profile. But what I want to draw everyone's attention to is that column mean change in EGFR from baseline. Now, just a couple of caveats. These are early phase studies. Some of them are uncontrolled and they're small numbers. But look at that in a group of patients that are high risk for progression, where we would predict that on a placebo arm, patients would lose around 5 to 6 mils of GFR over a year. And what we're seeing here is almost no loss of GFR, and in fact, potentially an improvement in GFR with these agents. And this is something that really is unheard of, Kirk, in terms of my experience in IgA nephropathy. And I'll draw your attention to the atacicept phase T, which now has presented 96-week follow-up data, again reinforcing the fact that with this approach, patients are losing barely any GFR, where we would predict they would lose 6 mils per minute per year. So really exciting. But what we need to do is see that phase 3 data. And hopefully we'll see these phase 2 data replicated because I think these agents are potentially transformative in terms of our care for patients with IgA nephropathy. But let's go through some cases. I think you've brought a couple of cases, Kirk,
Yeah.
that we can talk through. So let's see what we think.
Absolutely. So I'll just give you a few snippets. The first patient is a 35-year-old female. She had a 2-year history of intermittent gross hematuria, and she went through a bit of a diagnostic odyssey, seeing urology, getting multiple rounds of treatment for a presumed UTI. She's actually at presentation didn't have other medical problems, was on no medications. And when we performed the kidney biopsy, she had a GFR of 82 mLs per minute. She did have proteinuria of about 1.1 grams and an active urine sediment with greater than 25 red blood cells. The kidney biopsy showed an M1E1 S0 T0 C1 MEST-C criteria. So again, how would you approach this patient, and any comments on the diagnostic odyssey that she's gone through?
Yeah, sadly, Kirk, this is what I see in my practice as well. A delay to diagnosis in a young person, um, which means the GFR is 82, but for a 35-year-old, I'm worried this lady has already lost significant nephrons and we've missed early opportunities to intervene. So I do hope the listeners make the urologist their best friend and go and chat to the urologist and say, we want to see patients, or at least have them discussed. If you've seen someone with hematuria, the urological investigations are normal. The next call is to the nephrologist to say, do you want to see this patient? Rather than waiting and waiting for that person to present late. So I do think this is really important. I'm worried about this lady. She has significant proteinuria, she has hematuria, and she already has an abnormal GFR. She's only 35. My goal is for this lady to never see a dialysis machine, which means I need to keep her kidneys going for the next 40 to 50 years. And I truly believe she's already lost significant nephrons. So I need to address her disease. I need to address the immunological aspect of this disease. And I need to also address the fact she's already got established CKD, in my view. In terms of the immunological choices, that is very much going to depend where our listeners are sited in the world. You're very lucky because you have 5 approved treatments in the United States. I have 2 in the UK. And in some parts of the world, there are no approved treatments. So the treatment choice will very much depend on what you have available. Um, but I think she needs immunological therapy. I think she also needs CKD care. The worry for me here is this lady already has a good blood pressure, and any of the CKD treatments we're likely to use are going to drop that blood pressure lower. And I worry whether she'll tolerate that, but it's not going to stop me trying. Um, so I think in my practice in the UK, I have access to the gut-directed steroid Nefecon. I have access to general CKD care along with sparsentan as a dual endothelin angiotensin receptor antagonist. And for this lady, I would be wanting to give her Nefecon. I would be wanting to give her sparsentan, and I'd be wanting to give her an SGLT2 inhibitor. She's 35. I don't want her seeing a dialysis machine in the next 40 years, which means I've got to work hard from day one. What would you do?
No, I totally agree. And I think in this case, we, of course, were very concerned about her as well. Evidence of active inflammation. At the time that she presented, there was an actively enrolling clinical trial for an anti-APRIL agent, which she was enrolled in that study. Had to go on a RAS inhibitor, or at least demonstrate that she could tolerate or not tolerate maximum prescribed RAS inhibition, and so she didn't tolerate the maximal labeled dose, right, of an ARB, but as we got her on some, and again, she's proceeding in an anti-APRIL directed therapy. Of course, seeing her outside of a clinical trial context, that would also in the U.S. Go towards the anti-APRIL agent that we have available, right? The sibeprenlimab would be a good option. And again, trying to manage the CKD separately with agents that you mentioned. So spot on, again, depending on what's available and accessible to patients.
Great.
All right, so we're in alignment. So the second case we can talk about briefly again. This gentleman, 59 years old, he did have a very established history of hypertension and was on maximum lisinopril, presented with a lower GFR and 43 mLs per minute, significant proteinuria at 2 grams, less hematuria but still present, and he also had kidney biopsy showing evidence of inflammation and also fibrosis, right? M1, E1, S1, T1. So how would you approach this patient?
So this is a case very close to my heart, bearing in mind I'm 58 and very similar age to this guy. And again, I'm very worried about this guy. He's lost over half his nephrons already. He's only 58. And while the younger people in the audience may think that's very old, I'll tell you now it's not. I'm enjoying my life greatly. I don't want to be on dialysis in 20 years because I'd hope I'd be around in my 70s. So I want to get active with this guy straight away. I'm going to want to treat the immunology of the disease as before, and I'm going to want to optimize his CKD care very much so. So again, I use the drugs I have available to me, which in the UK would be Nefecon, sparsentan, and SGLT2 inhibitor, because I want to maximally optimize his blood pressure control and his CKD factors. And his blood pressure can probably take additional treatments. And I want to deal with the immunology. And of course, the clinical trial option is also the case. But I'd be very interested what you would do in a country that has 3 more approved therapies than I do.
Yeah, and I think here part of what we struggle with is getting all of them approved by the patient's insurance, right? So just because they are available doesn't mean we can't get them for each patient. So we often prioritize navigating that prior authorization approval process. And patients, of course, don't always want to start multiple new agents at the same time. So we have to prioritize in many cases. And I think here, as you said, going for the inflammation-directed therapy would be, I think, a priority, right? So again, emphasizing B-cell directed therapy up front, but also thinking about the progression. How often do you include assessment of the segmental sclerosis or the secondary FSGS in thinking about, say, some of the additional therapeutic approaches like endothelin receptor antagonism, et cetera?
So I think it's interesting, isn't it? You presented a couple of sensitivity analyses, and actually, those were very similar to what we've seen in the other studies, particularly of the endothelin receptor antagonists. All of the drugs we have work well, independent of baseline characteristics. So I don't think there's a reason not to use any of the available treatments. And my goal is to optimize immunological control and optimize CKD. I've not seen any data to suggest any drug is off the table in this situation, apart from obviously for tolerability and accessibility points of view. But from a purely philosophical view, I want to optimize both aspects of what's driving nephron loss.
Absolutely, very well said. So, of course, we recognize that patients are being cared for as part of a multidisciplinary team, right? And we want to emphasize the need for interprofessional communication at all times. We need our primary care colleagues, urologists, nurses, dietitians, advanced practice providers to be fully engaged, right, in diagnosing, managing these patients going forward. And again, we cannot emphasize that enough. We have repeated ongoing management of these conditions, and IgA nephropathy is a case study where inherently we do need to engage the full complement of the care team to prevent patients from moving towards requiring dialysis. So, Jonathan, do you want to have some key
Yeah,
takeaways emphasized for us? Yeah.
I hope we've convinced you BAFF and APRIL play key roles in driving pathogenic IgA production in IgA nephropathy, and that targeting these two key cytokines offers a novel therapeutic way to control the immunological aspect of this disease. And it's imperative that we have a multidisciplinary approach to managing these young patients who are living with the disease for the rest of their life and need multiple members of the multi-professional team to help in their management. And I think the priority now is we need to identify and access these patients early, which means early diagnosis, low threshold to treatment, and set the ceiling high. We want to get the rate of loss of kidney function back to what we see in the healthy population. That should not be in question. And we need to do that. We need to optimize patients' management. So I hope you've enjoyed this discussion. We clearly had a lot to talk about and not enough time. But it's goodbye from me, John Barrett and Kirk.
Yeah, thank you so much, Jonathan. It's been great.
Goodbye, everyone.